Dear colleagues and friends, the aim of this conference is to make you familiar with the latest scientific findings in the field of bone regeneration, but also to understand the mechanism of bone resorption. Everything is under the control of immune system. This is why this lecture is named Osteoimmunology. Immunology is a complex and difficult science. It has taken a long time, few years, to make this message simple and easy to understand. I hope that your approach to this exciting field will be easier and that you will be able to avoid mistakes that are leading to failures or secondary bone loss. Enjoy! We will understand how the immune system controls the bone formation and how this immune system regulates the bone resorption. And then we have a question. Periimplantitis should be considered as an immune disease. In 2000, we met a huge paradigm shift in bone science. Aaron and Choi published the first paper about osteoimmunology, and then osteology was replaced by osteoimmunology. The immune system is involved in all stages of healing. Immune cells contribute to the early stage of angiogenesis. Immune cells and immune factors are the key regulators in wound healing. Wound healing and osseointegration start by an immune reaction, the inflammation. What are the links between immune system and bone? Immune system is the key factor in bone homeostasis. It controls the bone formation by stimulation of osteoblasts. It regulates the bone resorption by inhibition of osteoclastic function. But the bone system influences the immune cells' functions, and then from a scientific point of view today, we consider that we have only one system, the osteoimmune system. We have two immune systems. The innate, the system we're born with, it's for immune defense against microbe and foreign bodies, regulation of adaptive immunity and tissue remodeling. The cells are the white cells and the innate lymphoid cells, cells that we discovered recently, just a few years ago. The adaptive is made by the T lymphocyte, it's the cell-mediated immunity. The B lymphocyte, it's a humoral immunity with the antibodies and with the stem cells. We know the immune reaction after the injury. It's the inflammation. But the main information that you will get today is that this inflammation must be brief. Should last maximum of 5 days. During the first days, the inflammation is always beneficial. We name it the positive inflammation because we have the activation of the repair genes, we have the production of antioxidants, and then the immune system is efficient. But if the inflammation persists after the 5th day, the effect is inverse, and then the inflammation becomes harmful. We name it negative inflammation because inflammation will induce increase of oxidant production. Immune system becomes deficient and we will have a negative action on bone. When we have a cell injury, we need to activate the repair genes. We have almost 500 genes, and the main activator is NRF2. This nuclear-related factor 2 is a transcription factor, means it activates the genes in order to downregulate the pro-inflammatory cytokine and to increase the antioxidant production. What's an oxidant? We name them a free radical, also reactive oxygen species. It's a molecule that has lost one electron or more. It's highly toxic. What's an antioxidant? It's a molecule able to provide one or more electrons to a free radical in order to neutralize it. And then you understand that we need to have a balance between oxidant production and antioxidant production. However, sometimes we produce too much oxidant, or we don't produce enough antioxidant. And then we say we are in oxidative stress. Oxidative stress leads to major cells issue. It attacks the DNA, the cell's membrane, in order to damage the cells in contact with the oxidant. And then the white cells are damaged, leading to an immune deficiency. Wound healing is compromised, and then you understand why we will meet more failures and more complications. Increase of oxidant in osteoblasts is the critical component of the pathophysiology of bone loss. Excess of oxidant will increase the rankle production, and then we will see the increase of osteoclasts coming from macrophages and inhibition of osteoblasts, leading to a failure of bone remodeling. Then we will meet a continuous bone resorption. Bone does not resorb as a melting ice cream under the sun. Bone resorbs because it doesn't remodel. That's it. In order to give you another example about the remodeling failure following oxidation, after extraction, we know that the bone has no mechanical activity. But we know that inactive bone becomes inflammatory, and then high level of inflammation means increase of oxidant. Bone oxidation will follow with a remodeling failure, and this is why and how the ridge resorbs, because the bone is under oxidation. When we meet a bad outcome, any kind of it, there is only one answer, one explanation: too much oxidant, related to a long-term or intense inflammation with an immune deficiency. Then infection is logic, resorption is mandatory. But now we understand why we meet fibrosis. Fibrosis is the result of a long-term inflammation and oxidation. We know that diabetic and smokers, they are meeting more complication because they are in oxidative stress. Diabetes is a chronic inflammatory disease. Hyperglycemia induces oxidative stress. Diabetics are deficient in vitamin D. What is the issue with the smoking? The issue is the smoke. Because the smoke breaks down the antioxidant into the gum. But smokers are deficient in vitamin D. It's logic when we meet a failure of osseointegration to see the fibrosis. Because when we don't achieve osseointegration, we achieve fibrosis because of the long-term inflammation. Then let's go to see the origin of oxidative stress. Too much oxidant or not enough antioxidant. We will analyze each one by one. First, in pre-op, we need to assess the level of oxidative stress with two markers. We have two markers of oxidative stress, cholesterol and vitamin D. We know the cholesterol. We have two kinds of cholesterol. It's the HDL, which is the good one because it's an antioxidant. And the LDL is the bad cholesterol because it's an oxidant. And then the LDL will induce osteoblast oxidation. If the LDL is less than 1.4, the osseointegration will be delayed. If the LDL is above 1.8, osseointegration is impossible, even in dream. This is why I recommend you to test the cholesterol in pre-op. We know vitamin D produced by sun exposure into the skin or by diet. Then it goes to the blood with 2-hydroxylation and producing an active hormone. Vitamin D is an hormone with two actions. First is endocrine with the calcium metabolism, and second, paracrine, anti-inflammation and antioxidant. And this is why vitamin D has an immune function, because it increases the antioxidant production. Below 20 nanogram, vitamin D deficiency has a causative role in the systemic inflammation. Then people will be on oxidative stress. When we lose the bone around the implant, please first check the cholesterol and vitamin D. Please check the cholesterol and vitamin D. And then we understand why the bone resorts, because it doesn't remodel around the implant. Because high cholesterol, low vitamin D lead to oxidation, immune deficiency, remodeling failure, and then bone loss. Most complications can be explained. Allergy to penicillin, we know that there is an increased risk of surgical site infection. We have a high rate of failures. And allergic, when we replace the amoxicillin by clindamycin, we see the failure rate increasing to X3. But allergy is a dysfunction of immune system. And we know the responsible, the T lymphocyte, which will release in long-term inflammatory cytokines. Then we will have an increase of oxidant production. But we know that allergic are deficient in vitamin D. They are not able to produce enough antioxidant. And the conclusion is that these patients are in oxidative stress. More infection and failures is logic. Sometimes we do augmentation and we meet resorption or fibrosis, or both. When we do an augmentation, the condition is the quality of the gum, the thickness, the biotype. And when the biotype is thin, then we know that the bacteria, they penetrate and spread to the periodontium, inducing a chronic inflammation. And we know what happens in chronic inflammation. a chronic release of inflammatory cytokines, leading to oxidation. And then we will meet fibrosis or resorption or both. We are advised to place a collagen membrane. What is the function of the collagen? It's not a cell barrier. The collagen is an immune barrier, blocking the cytokines coming from the gum. But we can start to talk about if the gum is not inflammatory. Do we need a membrane? No. We don't need a membrane if the gum is enough thick, because the bacteria, they don't penetrate, the periosteum will do the job because it's a collagen membrane. When we do an augmentation, even if it's autogenous, if the gum is inflammatory, the bone will resorb, even if it's cortical. When we meet a resorption, it's because of the inflammatory situation of the gum, which induce the underlying bone. We have another problem is the foreign body reaction. We know that when we introduce a biomaterial, we induce a foreign body reaction. The foreign body reaction is the less when we use human because antigenicity is the same. But today we know that even if we use porcine, we will have a low level and short-term inflammation. Then we have a positive inflammation without oxidation. But if we use less compatible material as synthetic or bovine, we will induce a long-term inflammation. And then into the graft, we will meet oxidation. And we understand why we meet connective tissue, fibrosis, or encapsulation. It's because of the inflammation into the bone graft, not from the cells coming from the soft tissue. The response, the immune response is an innate immune response to biomaterial. And then we understand how the encapsulation occurs with the giant cells. We meet also oxidation when we have a long-term ischemia. But how a tissue turns ischemic? Pressure or tension leads to loss of vascularity. Simply. And then when we see the bed ulcer, we understand what does it mean pressure. Constant pressure on skin will be followed by mandatory necrosis because of the ischemic function of the pressure. Tension or pressure will induce a hypoxia, soft tissue oxidation or bone oxidation, and then bone loss. In the two situations, we will meet bone loss. Tension. We know that tension induces ischemia and oxidation. Then we need to be careful about the tension when we do the surgery. When we have this kind of periimplantitis, look at the tension. There is no vestibule. Bone loss follows chronic tension. We have also oxidation by unreasonable pressure, means inadapted torque. Pressure on bone, how the bone reacts. We know since a while from the Hooke's law how a material reacts to pressure. It reacts according to its density. What does it mean? It means that when the material is soft, there is no stress. When the material is strong, we will meet a high stress. In bone, when the bone is cancerous, we know that this bone is flexible, then there is no stress. When the implant is in cortical zone, the bone is rigid, and then there is a high stress by the compression. Placing the implant, we know what is the difficult place, the cortical zone, because this bone has no plasticity, has a poor blood supply, and then compression will induce oxidation, and this is how occurs marginal bone loss. For periimplantitis, we see that the resorption always takes place in cortical bone. If the cortical is sick, we will meet cratering, because any compression of the cortical bone will be followed by resorption, by oxidation. This is an example. When we place the implant into the bone graft, we often make two mistakes. We believe that bone graft must be very dense. And then we place our implant with high torque because we want to achieve high stability. But from a biological point of view, bone graft is not flexible. Then it behaves as cortical bone. Any pressure will be fatal to the graft. Then, understanding how it works, we have an objective. We would like to enhance the immune system. We would like to avoid immune dysfunction. How? First, by increasing the antioxidant production in order to improve the immune response, because we will shorten the inflammation. We have different action to do. First is the NRF2 activator. It enhances the production of oxygen because oxygen penetrates the cells and damage the DNA and the membranes. Then the NRF2 is coming to activate the RNA in order to produce antioxidant. And this antioxidant will come to neutralize the oxidant. And this is the job of the NRF2. The main activator is the vitamin D. Numerous genes determining immunity, bone growth, remodeling are vitamin D dependent. This is why we do systematic testing. We do systematic supplementation. And if the patient is deficient, we will advise supplementation for the whole life. The daily dose is from 2,000 to 10,000 units a day, according to the blood test and the inflammatory level. Vitamin K2 enhances vitamin D efficiency. It protects against oxidative stress, cells death. Vitamin K prevents bone resorption and promote bone formation, etc. We need 100 micrograms per day. Vitamin C, it's a powerful antioxidant. We cannot be produced by our own. Then we need to take it daily because we have different action on the bone, on the soft tissue. The daily recommendation is 1 gram per day. But the most sensible patients are the elderly, the smokers, and the diabetics. Melatonin is a powerful antioxidant, and it's a hormone produced by the pineal gland, and it decreases with aging. We have a lot of action on oxidation, inflammation, bone. 2 milligram minimum per day. Zinc. Zinc is a very interesting product because it's a mandatory component of key antioxidant enzymes. 30% of zinc is localized in bone. We have action on inflammation, wound healing, infection, immunity, bone. But if we have a deficiency, the immune response are suppressed. This is very a problematic issue. We need at least 25 milligrams per day. But we have other pathways for antioxidant production. We know the probiotics. Now we are facing a new science, osteomicrobiology, the role of microbiota in bone homeostasis. We know that this microbiota has a huge influence on immunity, on bone, on most of the biologic cascades in the body. The microbiota is influent. Vitamin E, we know that it's a vitamin that protects the bone with anti-inflammatory and immunomodulatory effect. It prevents diabetes-induced oxidative stress. Daily recommendation is 15 milligrams. Copper. It's involved in bone formation and mineralization. If deficiency, we have an impaired immunity and increased infection by an impaired, cholesterol metabolism. Daily recommendation is 2 milligrams per day. Magnesium. Anti-inflammation, antioxidation, but involved in more than 600 enzymatic reactions and mainly stored in bone. Daily recommendation is 300 to 400 milligrams per day. Omega-3, strong anti-inflammation without side effects. Protection of the bone with 1 gram per day. And then, if we want to boost the patient, we can do it today with this easy cure for 2 months, the Immune Force, produced by Immune Pharma, and it has all the molecules that we need to improve and to enhance the immune response. We need to start at least 1 week before the surgery. But it's not finished. We have other solutions to improve the immune system. We have the autophagy. Ozumi got the Nobel Prize in 2016 because he was the first to explain autophagy. When the cells are in fasting, they organize their own cleaning and eliminate unwanted substances, including oxidants. Fasting is a physiological detox. Simply, you want to detoxify, stop to eat. We have a huge evidence about the improvement of innate and adaptive immune system and autophagy accelerate wound healing through angiogenesis. How to induce autophagy? By intermittent fasting. What is intermittent fasting? Is to be in fasting at least 16 hours from 8 p.m. to noon. 16 hours. Is it difficult to stay in fasting 2/3 of the day? No. You need just to miss the breakfast. Simply. And we recommend to make 10 days of intermittent fasting. 5 days before the surgery and 5 days after the surgery. Steroid. It's beneficial, of course, because cortisone shortens the inflammation duration. We need just to give them one single dose when we do the whole osteoimmunology concept. One single dose, 1 hour pre-op. 1 milligram per kilo or 0.2 milligram per kilo for dexamethasone, means intravenous. Can we improve the immune response with antibiotics? The first publication about macrolides was in 1987. And during the COVID, which is a virus disease, in logic, we don't need antibiotics. But we met alone a large use of azithromycin, because azithromycin is the most immunomodulatory macrolide, most powerful immunomodulatory antibiotic. And then I said in my mind, we need to start. After the lockdown in May 2020, patient came for a bone augmentation, vertical, and the surgeon made the vertical augmentation with a mesh, and after 6 days, he came back with a monumental infection. What is a monumental infection? A lot of pus, pain, swelling, everything is bad. So the surgeon called me to get an advice, and I said, don't touch, please. Give him just 3 pills of azithromycin today and 3 tomorrow. That's it. And then we will control the patient in 2 days. Surprise, after 2 days, there is no sign of abscess. Full recovery in 1 week, full. But the last surprise was the success of the graft. We had a huge abscess and the graft was a success. You can imagine that it's a huge change in our reflection. Then we came back to try to find all the explanation into the literature. Azithromycin inhibits oxidative stress. Azithromycin has a specific target, the soft tissue. It's stored into the polynuclears and the fibroblasts, but with a very high ratio, until 150 compared to the extracellular fluid. It means that the concentration of azithromycin in soft tissue is very high. We have another interest. 1 dose is active for 1 week. It means that 1 dose per week is enough. We don't need to give them every day. And we see that azithromycin start to be considered as more efficient than amoxicillin in prophylaxis. What is our updated protocol since May? We treat all the cases with the same protocol. 1 box azithromycin, 6 caps. We give to the patient 4 caps the night before. and we give to the patient 2 caps at the 5th day or 6th day. Then it's 1 box. We cover 2 weeks with this strategy, but we don't forget that the main issue is when we have a synbiotype or inflammatory soft tissue. Then it's logic to recommend to give to the patient every week 2 caps during 2 or 3 weeks more in order to help to reduce the long-term inflammation into the periodontium. But what gum loves most? Azithromycin powder on sticky ball. How to get the powder? It's very easy. You go to the pharmacy and you ask for Zithromax or azithromycin for kids. It's a bottle of suspension. And then the powder, you use it directly from the bottle. We don't need to ask for caps or anything. When we have a patient allergic to penicillin, we follow the same protocol. 4 caps the night before, 2 caps at 5th day. But it's not enough. Why? Because we need to increase the immune system. Because this allergy is an immune disease, at least with vitamin D. Do we use still metronidazole? No. It's replaced by topical azithromycin. We need to take care about the tension. First is to over-release the flap. Not to release, to over-release, in order to leave the bone very comfortable under the flap. We need to apply a specific suture in order to reduce the tension. And the only one suture which reduces the tension is the apical mattress suture technique. It's a horizontal mattress, but very deep into the vestibule, 1.5 centimeter from the margin, and then we stop all the tension because the flap is fixed very deep into the vestibule. This is a case with a classic suture. And look, when we change to the apical mattress, then we see that in the buccal zone, there is no tension and no mobility. This is one and second case of full opening. And then look, we have the apical mattress without a primary closure. And then we see the powerful of the apical mattress. There is no mobility, no tension. Truss must be removed after periostal attachment. But this attachment from the periosteum takes a long time, at least 4 weeks. 6 weeks to be full. 6 weeks. It means that we need to stay with the threads, and too often we remove them too early. They need to stay 4 weeks. Then we cannot use zinc nor Vicryl because braided sutures will take a lot of plaque and a lot of bacteria. We should ban braided sutures. We should use only monofilament. And look at the difference in the inflammation. Monofilament could be non-absorbable, but the problem is that after 4 weeks, the threads are covered by the gum, embedded into the gum, and therefore difficult to remove. Then the solution to use a monofil absorbable. Monoglyc is one of the series of the list of the name, but this has a perfect and ideal absorption time is 4 weeks. We need to avoid the pressure on the crestal bone. Means we need to over-drill in order to make space between the implant and the bone, the cortical. Then we are sure that there is no pressure, zero pressure on the crestal bone. How to do it? With a contouring or with a larger drill, 2 mm depth, or to place the implant subcrestal, 2 mm. We need to avoid the pressure on the graft by the soft tissue, because when we augment the bone, we induce a pressure from the soft tissue. And we name this protection from the pressure a protective bone regeneration. Means regeneration without pressure from the soft tissue. This is what we do with the Curie technique. This is what we do when we use a mesh or a PTFE reinforced or titanium. All this technique they have only one function, is to remove the pressure from the soft tissue. But we can use screws for tenting, simple. This is the best way to make horizontal augmentation, which is the most frequent. We need to shorten the inflammation into the bone graft. It comes from the mobility of the graft or from the foreign body reaction. The graft mobility is because of the muscles. And we know that when we fragment the bone callus, it becomes inflammatory. Then we have two solutions: using the sausage or using the sticky bone, or both. It's again better. Then it allows me to move into the PRF. What is the benefit? The benefit today is the sticky bone first, because each granule is surrounded by fibrin. And we know what is the function of the fibrin. It's the support for cell adhesion, for migration, for growth and differentiation. But it's also the structure where the first new vessels appear. And then today, when we do an augmentation, we have different ways to prepare the sticky bone. We use the gel, and then we can fold the graft 2 times, 3 times. We adapt the shape and the thickness to the case and to the indication. What we want is to produce one piece of sticky bone in order to make a very simple bone augmentation in the buccal zone. You see, then we fold and we have one piece that we will go to apply in one shot. This is the sticky bone that we use. And then we can go to the side to apply in apposition. But this is one technique, it's not the sole technique. This technique is for grafting in apposition. And you see, the full piece is placed in one shot. But we can use the palm swing in order to prepare a sticky bone very fast, in only a few seconds. We name it the sticky bone express. And then this sticky bone is for filling any kind of site, the socket, or a bone augmentation with a mesh, for example. But today we have also more information about which cells do we have. My objective was to increase the white cells, because the immune function of the white cells. We need to increase the cells, not only the white but the platelets, in order to produce more growth factors. But today we have also another benefit. It's the production of stem cells. As we decrease the speed, as we increase the number of stem cells, mesenchymal stem cells. And we know that the stem cells, they reduce the related markers of oxidative stress and inflammation. It's a very good help when we want to reduce the inflammation. And this is what we can do with the PRF. If we analyze the recent publication, we see that we have angiogenesis, we have inflammation and inflammatory cytokines, we have osteoclastogenesis, which is reduced, and then we have a conclusion. PRF is a powerful anti-inflammatory. PRF is antioxidant. Recently, it was introduced as a new technique, the horizontal centrifugation, showing that we can increase 10 times the platelets and white cells. Who can believe? Who can believe that just changing the angulation will give you 10 times more cells? Only ignorant. Today there is no evidence. All the publication comparing angulated and horizontal say that is not significant. Then we can say that there is no interest for horizontal centrifugation. We need to minimize the foreign body reaction. The best choice is human or porcine because we will have short-term inflammation. Allograft, yes, but we see that we lose the volume. This is the only one issue in allograft. And this is why today this new porcine bone is getting more interest because it behaves as allograft and xenograft. There is no immune reaction and we meet the volume maintenance. So now all pieces of the puzzle are in place. We know what we want. We want bone and stability, means remodeling. And for that we need both osteogenesis and osteoclastogenesis. The first condition is to have enough antioxidant. Because with the antioxidant, we will get the immunity, and with the immunity, we'll get the vessels. Very simple. But please, when you get the vessels, don't kill them by a wrong protocol, forgetting pressure or forgetting tension. If we want to increase the antioxidant, we know the solution. Vitamin D, all the immune supplements, PRF, autophagy. If we want to have a good immune response, we need to avoid the inflammatory biomaterials, means synthetic or bovine. We need to increase the gum thickness. We need to use azithromycin. When we apply the protocol, this is what I said all the time before, we will make a quick recovery. And now, as we delay substantially the risk of infection because of the immune response, we can leave the wound open. Yeah. Open wound is now the revolution of the future, for the future. First is the quick recovery. Surgery, 4 days after, what we can say? healing is achieved. There is no inflammation. Huge inflammation before, 3 days after, the site is healed. We said inflammation must stop at 3 days. At 5 days, sorry. At 5 days. Yeah, look at the gum at 5 days. How the healing is fast. Look at 6 days. How the healing is fast. We have seen the threats. But now we go to leave the wound open. Without fear of infection, the gum will come. But PRF is playing a huge role. We cannot make open wound without PRF. And then we can achieve to get a very, very nice keratinized tissue and very nice bone formation. When we have teeth in the palate, we know that with this situation is difficult to close. To achieve the primary closure, doesn't matter. We leave open. And we know that we will get the closure, the bone, and the soft tissue thickness. We can make augmentation, and at the closure, it's difficult to close. But today, we know. We are quiet. I cannot close. I will not make tension. I leave open. Look how the gum is happy after an open wound. We place an implant. We are in an aesthetic zone. The challenge, the aesthetic challenge is huge. But it's difficult to close. No worries. Don't close. And then you will get a keratinized tissue. We are getting the help now from 2 new products. The blood stop, which has cellulose sheet, and the Perker, which is an acrylic bonding technique. And then we can make the increase of the soft tissue without soft tissue graft. We can make the increase of the soft tissue without soft tissue graft. This is a case where we had the infection into the site of the molar, huge infection, and then we used only PRF and periacryl in order to close the site. 3 months only to achieve a full bone regeneration without bone graft. And look at the amount of bone into the site. The soft tissue is not enough, no problem. We put the PRF and then we leave open. But you see that the apical mattress is still mandatory. And then you can increase the band of keratinized tissue. This is a case of osteonecrosis. You see that after extraction, then the site was clean and filled with PRF, but the only one good solution is to leave open, not to try to close. PRF will do the job. And then after 3 months, everything is okay. There is a lack of soft tissue with a short vestibule here. Then the surgeon started the vestibuloplasty with a split incision, suturing the flap to the periosteum and covering the site with PRF. The membranes are sutured because we need to fix them. And 1 week after, we are meeting a new gum, a new keratinized gum. So, the first lesson from osteology is that the immunity is mandatory. If we want osseointegration, if we want to maintain the bone, but immunity requires a high level of antioxidant. Lesson 2 from osteoimmunology: what is the major benefit? Pain less. Most of the case, they don't take any one painkiller. It means that the inflammation is very low, very short. Lesson 3: we know what happens after oxidative stress: immune dysfunction and bone loss. Then we should regard the periimplantitis as an immune disease. The question is, how occurs this immune disease? We know, following chronic inflammation, following pressure, following tension, and following soft tissue incompetency. Chronic inflammation induces oxidation and bone remodeling failure. We know all the chronic inflammatory disease: autoimmune, diabetics, allergic, obese, high-level cholesterol, etc. We know the situation where there is not enough antioxidant, smoking, and deficiency in vitamin D. How to manage this patient? Because they have their chronic disease only by antioxidation. This is how we decrease the level of inflammation, and this is how we increase the success rate. We have the immune disease following pressure on bone, and we know that it will induce remodeling failure. Who is responsible? The surgeon. The periimplantitis is scheduled the day of the surgery. Too much pressure at the neck, because here there is cortical, and then the pressure is too much, and then the bone resorbs. Why this implant has still the whole bone? Because cylindric implant is not very stressful. Pressure is very less. How to prevent? By avoiding the pressure on crustal bone. We have different kind of bone. First is, how is the cortical? We need to assess it. Class 1, type 2, type 3. And then on the left, we can say, yes, we can place the implant with high torque and we can load it immediately, because the implant is in cancellous. Here, we cannot place implant with high torque. We cannot make immediately. Definitely never. Because if we do it, we will lose the implant after a while. We need to anticipate the bone stress. This is how should work the planification. And then when the implant is placed, it should be with a very low torque, over drilling, and definitely forgetting immediate loading. 10 years after implantation in spongiosa, there is no reason to lose the implant and the bone. 1 year in cortical, and you can see the disaster. We say that bone graft is not flexible, and then we need to take care. If we place the implant with torque, we will lose the bone. Into the sinus, the same. In bone calvaria, the same. After using BMP2, the same. After waiting a long time, because when you wait 1 year after a bone augmentation, obviously the bone is very dense and the stability is not possible, because when the bone is too dense, it's very easy to kill it. It's better to make an early re-entry because we will have a low tokenization because the bone is not very dense. We will do definitely a crestal over drilling, and then it's easy to get a full stability. It's very easy to get full stability. We need to place the implant with a low torque. Please forget definitely immediate loading in bone graft and try to make a crestal over drilling. Following tension is the same inflammation, oxidation, remodeling failure, coming from an inconsistent flap release or inadequate flap closure. Again, surgeon has a causative rule. Periimplantitis is scheduled the day of the surgery. How to prevent? Over-release, apical mattress, and if the closure is difficult, leave open. It's much better to leave open than to try to close. Soft tissue incompetency. What does it mean? Incompetence to avoid bacterial penetration in periodontium. It's the thin biotype. Yeah. Look, we have two kinds of gum thickness. We will have two kinds of bone resorption because the soft tissue thickness has influence on the bone loss. But in this case, I showed you that it's possible to be the overpressure, but also maybe the soft tissue is not the same. Soft tissue thickness is not the same around the two areas. This paper is showing how many people are living with a thin biotype. 1/4 of men, half of women. What does it mean? It means that 1/3 of adults are naturally candidate to periimplantitis. 1/3. And these people, if you don't manage the soft tissue around the implant, means reinforcing the soft tissue, the periimplantitis will be scheduled the day of the surgery. Finally, who is the great responsible of periimplantitis? The surgeon with a wrong surgical protocol. Let's go to see this case. No pressure with implant, no tension, controlled biology, overgrafting, and then at 6 months, we have a very good periodontium. Effective means sick. What will happen in the next 15 years? Nothing. Why? Because everything was done perfectly. And you understand that the surgery is the good surgery, is the condition to achieve long-term stability. Nothing can happen after 14 years because everything was done biologically, surgically. Same, 14 years. Everything was done. Biology and surgery. If you want to treat the periimplantitis, you understand that it's the management of the periodontium, inflammation. The first is to clean the surface. But before to start, we need to improve the immunity. We need to increase the soft tissue thickness. We need to forget the inflammatory biomaterials. We need to use azithromycin, local and general. And obviously, over-release and adequate suture. The last lesson from osteology is that we will get a quick recovery and long-term stability. How do we set the osteoimmunology protocols? We do everything that biology likes. Everything, but too much. This is how we design the overall concept. But our benchmark is the tibia fracture. We know that a tibia heals in 4 weeks, and we can load it 2 weeks after, 6 weeks in total. Means a normal time for healing, for bone healing, is 6 weeks. It's very good. Look at the bone above the implants, but it takes 2 months and a half. Can we do less? Yes, we can do in 2 months because we push the biology. But can we do less again? Yes, in 6 weeks. Exactly like in the tibia. And this is the message that I would like to give you today. If you do everything well, the healing will be very fast. Mandatory. You don't need to wait 9 months. You need to wait only 2 months in a horizontal augmentation in the maxilla. Only 2 months in a vertical augmentation in the mandible. Look at the reopening after removing the mesh. Seven weeks means 1 month and a half after vertical augmentation in the mandible posterior. Very fast healing of this huge defect. Only 2 months. It's enough to place implant and look after 2 months again for the soft tissue management. How is the bone? Only 3 months to achieve a fantastic healing in vertical and horizontal augmentation just with screws. This is an interesting case. Full periimplantitis with horizontal bone loss in the aesthetic zone and vertical in the 2 posterior zone. And then the solution was to make with, of course, with mesh, sticky bone, etc., osteoimmunology, and then after 4 months and a half only. There is no collagen. We don't need collagen when the gum is not inflammatory. Look at the volume of the bone with the implant placement, and we did some course. Only 20% of connective tissue in the anterior zone, only 10% of connective tissue in the posterior zone. What does it mean? There is no inflammation. And when you don't have inflammation, you don't have too much connective tissue. Simply. Look at the follow-up at 3 years. All the bone around implant is stable. This is another augmentation, horizontal, with the same technique, with the same materials. Reopening at 3 months, again with a micro sticky bone, and then the reopening at 5. Means at 5, we start the soft tissue management. But we are not stupid. When we have inflammation, we use a collagen membrane in order to get the same results. Simply. When we have the indication of the collagen, we do it. My friends, it's time to say thank you again. You need to think osteoimmunology from the morning to the evening, anytime, all the time. You are free to ask us for more information, for protocols. We have the full protocol that we can send you by mail. Just make the request and we will send it to you. Thank you, my friends. and enjoy osteoimmunology.